Okay, thank you very much, Eran. It's a great pleasure for me to talk about the work we actually established in not only Rotterdam but also in the Netherlands. This is a view of our university. So here is only the basic science being done. But whenever you look at another part of the hospital, this is actually our hospital. So here you see the same building you saw before, and this actually is completely the hospital, and this is all scientific work. So actually my place is here, and the ORs are on the 6th floor at this building. So I'm involved in more than 25 years in pancreatic cancer, but during the weekends I'm also a team physician of one of the most famous clubs in the Netherlands, which actually is called Feyenoord, and that's only about 5 minutes away. So I joined that club around 10 years ago when there was a medical problem, and all the players, you know, they were complaining about injuries, etc., etc. But that was mostly due to the trainer, and then, you know, they contacted me, and what you can see here, I'm sitting here on the bench, and sometimes you see that some education can help, you know. If you see the trainers, then it can be easy to have some education that you just wear your sunglasses. But that was about 8 years ago, and last year we became the Dutch champions, so that's actually also part of my work, but that's only in the weekend, because mainly I'm focusing actually on pancreatic cancer. And I will briefly go to some of the incidence parts, which actually in my opinion are very important, because this is how it is predicted to be in a few years' time. And you can see that at least in Europe, pancreatic cancer will be the second cause of death. And from a funding point of view, it's very important to see that already in 2017, more patients died from pancreatic cancer than from breast cancer. And if you look, for instance, at the Dutch Cancer Society, the foundation, which actually gives all the funding for the research, and you look at the breast cancer and pancreatic cancer, then pancreatic cancer is not 10% of all the funding which actually is going to breast cancer. But this year, already more patients died from pancreatic cancer than from breast cancer. And what is also very annoying to see, and that's what we discovered in the Netherlands, is that we have two registries in the Netherlands. One is the incidence of cancer, and this is the mortality. So that's the Central Bureau of Statistics, this is the Dutch Cancer Registry. And what is very intriguing to see is that the mortality was always in every year higher than the incidence. Well, that's actually not possible. So that means that we looked into a cohort of patients, which we actually do have in the Netherlands, which actually is called the Ergo cohort, that's in the north of Rotterdam, where you prospectively follow all patients above 45 years. And they already consist of more than 15,000 participants. So what we actually found there was that in that cohort, there were about now already 120 patients with pancreatic cancer. Most of them were female, and the most striking thing was that the median survival of all those patients with pancreatic cancer was only 71 days. And most of all the patients actually died of pancreatic cancer. And what turned out, you don't have to read this slide completely, but this will show you that there was really a very under-registration in the Dutch Cancer Registry concerning patients with pancreatic cancer. In every age group there was an under-registration of the incidence of pancreatic cancer. So that means that less than 30% of the patients were not registered in the Dutch Cancer Registry. So that means that the estimated incidence of pancreatic cancer in the Netherlands, which actually is a country of about 16 to 17 million people, is that about 8 to 10 people die every day of pancreatic cancer. So that means that nowadays, at least in the Netherlands, it's the second leading cause of cancer, and I think it will be the same in Israel, that we detect patients in about 40% already with metastatic disease. 40 to 50% of all the patients actually do have locally advanced disease, and only very few patients actually come to curative resection. But what about curative resection? We all know that also if we look in the Netherlands, but also if we look in the literature, long-term survival, even after what we as surgeons consider an R0 resection, is less than 10%. So that means if you look carefully to the literature, there are only very few patients described who actually live longer than 5 years in all the literature of the last 75 years. And that's due to the recurrence, and recurrence which actually always takes place local, regional, peritoneal, or the liver. And what the Americans did, they always do then a comparison of normal resections with extended resection, but in pancreatic cancer that didn't have any benefit for the patient. And this is, you are all familiar with this. This is just a small pancreatic tumor which actually consists of a very hard core, which you can see here. But I always show this also to the residents to show something, and it's very intriguing that these are all very old studies, and none of these studies are actually currently being published anymore. But this slide, for instance, show you that what we consider as a radical resection, it means that there is much more tumor around. For instance, if you look at this slide, here you see the lymph node involvement on the location of the primary tumor. And you see that in around 30% of the patients, already in just small tumors, the aortic cave lymph nodes actually are positive. And those are the lymph nodes we actually never take away. The same consists of the lymph nodes around the SMA. Of course, we take out the lymph nodes in the hepatoduodenal ligament, but here again, if the cancer is located in the uncinate process, you see that there are a lot of lymph nodes positive, and those lymph nodes actually with a standard resection we never take away. And also in this slide, if you look at just normal histology, you can see that if you look at negative lymph nodes, actually lymph nodes in pathology found to be negative. If you do, for instance, RT-PCR, or you do what we call the sentinel node technique, so that means that you make very small slices of all the lymph nodes, you see that although the lymph nodes were considered negative, most of the lymph nodes who actually were considered negative do contain tumor cells. And this, of course, is very clear in pancreatic cancer, that pancreatic cancer is actually characterized by the angio invasion and also the peroneural invasion, we can see it very clearly. So that means if you look, and for instance for us as surgeons, that's very important. If we consider a patient to have undergo an R0 resection, what we actually find is that what I mentioned before is that there are positive lymph nodes between the aorta and the caval vein. There is in a lot of patients already nerve plexus involvement. There is lymphangiocardiomatoses. But what is most striking in all the trials which actually have been presented, that you can actually find viable cancer cells in the drain after a curative resection. So that means that, in my opinion, the dissemination pattern of pancreatic cancer actually is the limitation of surgical treatment. So we have noticed that for several years already. And as a surgeon, what we normally then do is see, okay, what can we do? So what we normally do is that as surgeons, we initiate adjuvant trials. As surgeons, we now have improved our knowledge of surgical techniques. We are much better in doing venous reconstructions in all kind. We reduce the complication, we reduce the mortality, but we didn't improve the overall survival of the patients who we actually have operated on. So what we started to do is then, we as surgeons, because these are all trials which actually is very important and intriguing to see, all kind of trials which were actually initiated by surgeons. The adjuvant trial started in the 1980s with the gastrointestinal study group in the United States and also the group from C.H.J, where you see that they compared surgery alone to adjuvant chemoradiotherapy. And they improved slightly actually the median survival. And these are the trials. This is the EORTC trial, the one we actually initiated from Rotterdam. And this, of course, everybody knows, is the ESSO trial, where they also compared surgery alone, here with 5-FU radiotherapy, and here with 5-FU and leukophorin. And they improved slightly every time the median survival. And these are actually the latest trials. This is the ASPAC3 and the CONCO trial, where you can see that with a combination of chemotherapy, in this case the capecitabine, and here again the gemcitabine, that you improve slightly every new study, actually the median survival. This, the last randomized trials, huge big trials, both from Europe with a lot of patients, where they actually improved again to prolong the median survival in those patients. But what is very intriguing of all these papers is that these papers do not present the data of intention to treat. So that means these patients are only selected when they were good enough to receive chemotherapy within 6 weeks after the operation. And that means that about 50% of all the patients who have been operated in these centers did not receive the chemotherapy. So these papers, in my opinion, are very misleading, because you should, in pancreatic cancer patients, always present the data on intention to treat patients, and not when you select patients who are young and fit enough to receive the chemotherapy. And for instance, in the Congo trial, but also in the SPAC4 trial, it turned out that about 40% of all the patients who actually were had the indication to receive adjuvant chemotherapy did not get the adjuvant chemotherapy. So these figures are very, very misleading in my opinion, because you always should go for the intention to treat. And this was a trial we actually published a few years ago. And it actually, the endpoint doesn't have anything to do with overall survival, but this was a trial where we put in all the patients who actually had pancreatic cancer, and we actually looked at whether it was useful to put an endoprothesis to drain before the operation or after the operation. And this is just standard of care. And if you look at the intention to treat of all these patients, then you see that the median survival in the whole group of patients in the Netherlands was only about 12 to 13 months. So this is intention to treat data, and the other picture that shows is not intention to treat, but it's very, very selected group of patients. So actually, we as surgeons, we normally are very optimistic, and we say, okay, you don't have metastasis, we can take the tumor away. So that actually to the patient suggests cure, but as I showed you, that's not always the case. So the realism is that 85% of all the patients actually do have an R1 resection, and there is in the majority of patients there's tumor left behind. 25% of the patients already present with recurrence within 6 months, and the median survival after resection is only 13 months. And as I mentioned before, after in pancreatic cancer, real pancreatic cancer, after 10 years, only 3% of patients are alive. So in my opinion, there is still room to improve. So then we take the next step. Then we look at neoadjuvant therapy, and neoadjuvant therapy is actually nothing else than a new way to help the patients. So we, as pancreatic surgeons, we need to look, for instance, also to a patient with esophageal or rectal or breast cancer, where actually the neoadjuvant therapy already is a standard of care. So that was actually also for us as the Dutch Pancreatic Cancer Group, the reason why we actually thought of giving neoadjuvant therapy in pancreatic cancer. And neoadjuvant therapy in pancreatic cancer actually has some advantages. It could downstage unresectable tumors. What we know, for instance, from rectal cancer is that the radiotherapy is much more effective in when the tumor is still in place with good oxygenation. It prevents, as I mentioned before, tumor cell dissemination, which actually is present during most of the resection in patients with pancreatic cancer. And it, in theory, could offer more arterial resections. Another thing is that, as I mentioned before, with neoadjuvant, you directly treat all the micrometastases which are present. And on the other hand, maybe we could assume that a lot of patients do not undergo an unnecessary resection. And what's, in my opinion, one of the most important things is that in 100% of your patients, you give systemic treatment, and not as an adjuvant treatment, where only 50% of patients actually do receive systemic treatment this time. And that all should actually lead to better overall survival. So what we did a study where we looked at the literature to see actually what was what was actually present in the literature concerning neoadjuvant therapy versus direct surgery for resectable and borderline resectable cancer. Well, there were a lot of studies, but not randomized studies. However, 38 studies with more than 3,000 patients, all based, and that's important again, on the intention to treat principle. And then it turned actually out that the median survival in the neoadjuvant group was always higher than the direct surgery. And also the median survival, especially of the patients who actually could undergo the resection, was much higher than the patients who had direct surgery. The resection percentages, of course, in the direct surgery group was higher, since some of the patients, and I will show you that later on, actually do not come to a resection in the neoadjuvant group due to progression during neoadjuvant therapy. But what is found in the literature is that the R0 resection percentages actually is much, much higher in the group who actually underwent neoadjuvant treatment. So then there was only one randomized trial, which actually was closed very soon, already after 50 patients, due to the interim analysis, which actually showed that the median survival in the neoadjuvant group was that much higher that they say, okay, well, you have to stop this trial because the neoadjuvant actually seems to be much better in the group. And again, what you can see here, that the R0 percentages also in this group of randomized patients was much higher than the patients who actually underwent direct surgery. So that meant that we as a Dutch pancreatic cancer group said, okay, well, we need actually to start up a trial where we go to evaluate whether the preoperative radiochemotherapy versus the immediate surgery for resectable and borderline pancreatic cancer could be established in the Netherlands. That should be a multi-center randomized phase 3 clinical trial. And just to give you an overview of how the Dutch pancreatic cancer group actually is organized, here you see all the centers in the Netherlands. The Netherlands actually is not a very big country, although it consists of more than 60 million people. Actually, the total surveys of the country is not that big. Just to give you an example, if you drive this way or this way, that will only take 1 hour and a half. And as Eran said, that's more or less the same as in Israel if you go from east to the west coast. So this is actually a very small country. And that means that here we have the central office. So when we have meetings, we always join in Utrecht, and all the representatives of the people who actually joined the Dutch pancreatic cancer group, which actually consists of surgeons, radiologists, medical oncologists, and gastroenterologists. And we join every 3 months to talk about research and to present our data and to see whether we can develop new clinical trials. So in that sense, I think the Netherlands actually is an ideal country for multi-center randomized controlled trials. So then, okay, we said the PreOPEC 1, which actually was funded by the Dutch Cancer Society. What they normally fund is all the database stuff. So they build a CRF for us, etc., etc. But we actually, as surgeons and also as medical oncologists, need to run the trial. So the aim of the study in the PICO analysis was to compare the neoadjuvant gemcitabine-based radiotherapy followed by adjuvant chemotherapy, which compare that to upfront surgery. And the objective of this study actually was the overall survival with a sample size of 242. So what is important here, you see the scheme of the randomized study. What is important is that we actually consider the resectable and borderline resectable. I will come back to that later on. But what is important is that in that study, since we found in the patients with locally advanced pancreatic cancer, we found that diagnostic laparoscopy has an overall yield of about 25% of small metastases, which could be detected by the laparoscopy. So we said in this group of patients who actually will undergo radiotherapy, it is important to exclude that those patients have metastatic disease, since we don't want to give them a local regional treatment when there is actually metastatic disease. So that's important. So in this group of patients, actually there was a diagnostic laparoscopy, and this was a group of patients who underwent direct explorative laparotomy. What is important is the inclusion criteria. Actually, in the Pancreas 1, we said, okay, well, let's actually start with patients who have a tumor bigger than 2 centimeters, because those patients actually will have a worse prognosis than the patients who have smaller tumors, so that means that we want to. And these actually is our definition of the Dutch pancreatic cancer group of borderline resectable and locally advanced resectable. So these are the main inclusion criteria of the Pancreas 1 trial. And what you should see is that this really differs a little bit from the NCCI criteria of resectability. And that means that actually we are a bit, how you say that we are a bit conservative in defining the resectable patients and also the borderline resectable patients. If you compare that, for instance, with the NCCN guidelines, where you can see that the portal vein and mesenteric vein involvement less than 180 degrees is still considered resectable. But what is intriguing to see is that in the borderline patients, now in the new guidelines of the NCCC, it says already that in the patients who actually do have borderline resectable pancreatic cancer, actually the neoadjuvant therapy is the main initial treatment for those patients. So this just to show you how it differs a bit against resectability criteria to the American criteria. So this again was actually the scheme. Here you see the randomization. The randomization took place before the diagnostic laparoscopy. Here the patients underwent direct surgery followed by 6 courses of gemcitabine. Here you see the radiotherapy, 1 course of gemcitabine combined with the radiotherapy, again gemcitabine. A new evaluation, surgery, and then followed again by the gemcitabine. So these actually were the inclusion over time, and what you can see is that always, that's always with a clinical trial. The initial start was actually rather poor, but then it really followed the expectations line. So that means that there were about 5 to 6 patients included every month in the Netherlands in this trial. So the baseline characteristics, what you can see is that the female were were nearly equal to men, and that difference in both groups. Neither the age, which actually was rather surprising to us that it was above 60 years of age. You see that the WHO classification was the same as well. The location of the tumor was the same, and also the percentage of borderline resectability. And as I mentioned, we are in the Netherlands very conservative, so we consider patients very soon, I should say, as borderline resectable. So that means that in the Pancreas 1, in our definition, half of the patients do already have borderline resectable tumors. So this is the flow chart. If you look at the upfront surgery group, we had 127 patients, and then there were some patients who actually, in the waiting time, actually already presented with progressive disease. There was one patient who actually had a heart attack, and 2 patients, well, after the analysis, we couldn't find the appropriate sense. So about 120 patients actually did underwent the explorative laparotomy, and what is important to see is that from those 120 patients, and that's what we also found in the other group, is that about 12% of the patients actually did have already metastatic disease, which couldn't be found on the CT scan prior to surgery. So what you see is that from those patients who actually had a resection, we were at least happy that more than 50%, so nearly 65%, actually all the patients could undergo the adjuvant chemotherapy after the resection. So looking at the neoadjuvant chemotherapy group, and then there you should have a good look, because that's really very different. So you see again in the diagnostic laparoscopy group, in the patients who underwent the neoadjuvant therapy, you see that all, as well as in the upfront surgery group, again 12 to 30% of the patients actually did have metastatic disease. So that means that the overall yield of the diagnostic laparoscopy in patients defined with resectable or borderline resectable pancreatic cancer is about 12 to 30%. So that means that in the Netherlands now we always, if we plan a resection, either robotic or laparoscopic or open, we always start with a diagnostic laparoscopy because that takes 5 minutes and it's really a benefit of the patient. So that means that from that 190 patients, 91 patients actually came to the chemoradiotherapy, and then you see that you also lose some patients who actually do have progressive disease during the chemoradiation therapy. Although there were not a lot of patients, only 10 patients were actually lost, and not all of them actually due to progressive disease, but unfortunately 9 of the patients actually did have metastatic disease developing during chemoradiotherapy. So that means overall that 72 of the patients underwent a complete resection, and if you consider that comparing the patients who actually underwent the resection in the upfront surgery group, you see that less than 20 patients, less than the 39 patients actually underwent a resection. And from those patients, more than 75% actually underwent the adjuvant chemoradiotherapy. So this scheme actually is again the scheme of the intention to treat principle of patients receiving neoadjuvant chemotherapy. So these are actually the preliminary results. This is the group of the upfront surgery and the neoadjuvant group, and what you can see is that actually the adverse events in the resection group or the neoadjuvant group actually didn't differ. But what is important again, of course, is that you again see a huge difference in the R0 resection rate of the patients who underwent the neoadjuvant chemotherapy. This is the overall survival. What is important to say is that we actually calculated the complete trial on 179 events, and this is only after 150 events. But what you clearly can see is that the median overall survival actually of the patients who underwent neoadjuvant therapy is already much better, although not yet statistically significant in the neoadjuvant group. So that means that the disease overall survival actually did already reach its statistical significance, where you can see that the disease-free survival was 10 months in the patients who underwent the neoadjuvant treatment. And this is also very important, and you should keep that in mind. This is a comparison of the group who actually all the patients who underwent the resection, but this is the group compared to the patients who actually underwent the neoadjuvant chemotherapy and also received after the resection the chemotherapy. And then you see that the overall, the median survival of those group of patients is more than 40 months. So that means whenever you're able to receive the complete treatment, neoadjuvant, resection and adjuvant therapy, then you see that you have a median overall survival which actually is very, very good. These are the figures of the metastasis at the local recurrence, and again, this also all favors actually the neoadjuvant therapy in the patient with pancreatic cancer. So both metastasis and local recurrence, you delay the development in the patients. So actually, I think we can conclude from the PreoPanc-1 that the median overall survival compared to the direct surgery group and the neoadjuvant group, although it doesn't actually is already significant, but this is only after 85% of the events needed actually is presented. But what we actually do see, and that's very important, that the R0 rate is much, much better in the patients who actually underwent the neoadjuvant treatment. And the disease-free survival also is much better in the neoadjuvant. And as I mentioned before, that the median overall survival in the group of patients who completed the therapy, so that means neoadjuvant resection and started chemotherapy, is 42 months, which actually is very important. So we expect in the beginning of next year, we expect to close actually the trial, and then we have enough events to make everything further significant. But we actually really suspect that the neoadjuvant therapy will be much better. But I come back to to something else now, because we are focusing on that as well, and I will show you some of the work we actually did, and which makes doing trials actually very, very interesting, not only from a clinical point of view, but also from a scientific point of view. But as a surgeon for more than 25 years, always looking at chemotherapy, always looking at radiotherapy, I was really wondering whether with the chemotherapy and with the radiotherapy, we always looked to the right target. So that means that also in pancreatic cancer, these are both the Nobel Prize winners. Here you see James Ellison and Asuku Honjo, who actually received the Nobel Prize for the immunotherapy. So at least in Rotterdam, we thought, okay, well, we should have a look at that as well in our patients. So we went into that. So that means we first started a very simple study where we looked at the systemic immune inflammation index, which actually is just based on the pre-operative lymphocyte neutrophils and platelet counts of all the patients who actually underwent a resection for pancreatic cancer. And just a very brief rationale is that the neutrophils and elevated platelets themselves really actually do protect the cancer and do have a pro-cancer effect, and the lymphocyte actually represents the effect of anti-tumor immune cells. And what's very easy to do, and we did that in all our resection pancreatic cancer patients, we looked at the SII of the patients who actually underwent resection. And here you see the survival curve for all the patients with a very low systemic immune inflammation index. So that means that in those patients the immune system was working pretty well preoperatively, and here you see all the patients which actually did not have good functioning. And you see that the overall survival time, the median overall survival time in the patients who actually do have a good functioning immune system preoperatively is twice or even higher than the patients who actually do not have. And in the multivariate analysis, it turned out that even the lymph node status or the level of CA99 was less important than the preoperative immune system function. So that is very important. So then what we then did, we started to immune profile all the patients with pancreatic cancer. And I will give you an overview of the first 100 patients. So we do have healthy control, we have resectable patients, locally advanced and metastatic patients. So what we do in Rotterdam is that we do the immune profiling of all patients who actually come to our clinic to do the complete blood profiling of the immune system. This looks very complicated, and it actually is. So don't look at it too long, but I will make it very easy shortly afterwards, because what we actually do is that we count the absolute numbers by flow cytometry and look to a variety of T cell markers, which actually could tell us something about the immune system. So this is how, for instance, the baseline systemic immune profile of all the patients with pancreatic cancer looks like. Always here on the left you see the healthy controls, and these are all kind of immune cells which actually we looked at of the patient with pancreatic cancer. And I don't want to make it too complicated, but the most striking thing is in all our groups was that, and that's actually very impressive. If you look at the CD8, so that means the T helper cells in all the patients with pancreatic cancer, all the patients who actually did have stable disease during follow-up did have the normal T cell, CD8 T cell levels. And what you see is that in the patients who did have progressive disease, the T cells actually dropped. So that means the function and also the number of the T cells dropped, which actually enhanced the progression of the pancreatic cancer patients. And what we also do is that we not only look at the immune profile of the blood, but we also look at the tumor cells. And what we then do is that we combine, as I mentioned before, the systemic inflammation index to what we see in the tissue. And in the tissue, again, the CD8, of course, the T helper cells is very important, where the FOXP3, so that means the regulatory T cells, which actually inhibit the functioning of the T cells. And if you combine that, then you see these graphs. When you have a good functioning immune system preoperatively, and actually in the tumor, high on CD8, you see that the prognosis actually is very, very good. And when it's the other way around, you have a very poor prognosis. So this just to show you how important, in my opinion, we already detected that the immune system for the survival is of pancreatic cancer patients. And as I mentioned before, Doing a study like the Pancreas study also gives you the possibility to study, for instance, the effect of the neoadjuvant therapy on the immune signature of pancreatic cancer patients. We all know that the tumor-infiltrating lymphocytes are very important. You have tumor progression, you have tumor suppression, and all the immune cells play a huge important role in that.